on. Yeah. More people are coming. Well, hello, everybody. We'll get started. My name is Mary Newman, and we are very honored that Dr. Sears will be joining us today and talking about confidence in you and your ICD. So, Dr. Sears is a professor in the departments of psychology and cardiovascular sciences at East Carolina University. He serves as division chief of innovation and research at the East Carolina Heart Institute. He also serves as an assistant program director in the ECU Cardiology Fellowship. In addition, we are very honored that he is a member of the Sudden Cardiac Arrest Foundation Advisory Council. Dr. Sears has published over 200 articles in the medicine and psychology research
You don't
literature.
mind hearing this, do you?
Can you hear me?
Yes.
Okay. He was named in 2025, he was named a world expert on defibrillators and ranked 11th all time in research contributions to the field among 24,000 authors on the topic. He was also ranked 42nd all time in his contributions to cardiac electrophysiology. He was awarded the O. Max Gardner Award in 2013 by the Board of Governors at the University of North Carolina, and this award is considered the highest honor bestowed to a faculty member in the UNC system. So welcome so much, Dr. Sears.
Well, good afternoon, everybody. Thank you so much. Appreciate that nice introduction and happy to be with you this afternoon. Let's see. Can you see my slides okay? There we go. We ready to rock and roll?
Yes.
All right. Very good. Very good. As a psychologist dedicated to the psychology of cardiology for the last 30 years, one of the things that I focus on with my patients is restoring confidence. Cardiac events shake people up. They shake your confidence about yourself, your confidence about your safety, and your confidence about your future. That's enough to shake people up pretty good. And so when we think about how do we restore confidence after so much has been at risk, we think a little bit about the kinds of therapies that we provide. We think about the defibrillator, rated recently as one of the 50 most important life-saving breakthroughs in the history of mankind. You're the recipient of a technology that has characteristics that are human-like. A defibrillator can both monitor your heart, watch your heart, if you will, write down what it sees, decide you might need some help, and provide that help. I mean, a bunch of humans mess that up. So this defibrillator provides you with some technologies that are quite unusual. And since the time I've been in the field over the last 30 years, we've moved a great deal from what I would consider basically medications that were not all that helpful to now medications that can help us both work collaboratively with the defibrillator, but also manage and change the course of heart failure or arrhythmogenic syndromes that we've never had before. In fact, we have a large many million-dollar trial where we're studying the role of medications versus defibrillators in outcomes and protecting lives. So we're at a stage in which both medicines and devices have accelerated in their expertise, if you will. So much so that when you look at some of the data, this is some data from Europe a few years, 3 years back, looking at 1,800 patients, that when this group of researchers asked, how would you rate your quality of life? Even with the defibrillator, in which there's no therapeutic benefit except creating a safety net, you start seeing that a large percentage of patients start saying things like, my quality of life's better because I have this defibrillator. Now, I don't want to sell you sunshine. There's a grind, man. This ain't easy. I mean, I have a clinical practice for the last 30 years because it's not easy. But on the other hand, these are encouraging data about, well, some people actually feel safer and improved as a result of this safety net. Some people using the subcutaneous ICD, so a slightly different device, similar kinds of levels of feeling improved quality of life. And then a device, the CRTD, which is the device that uses biventricular pacing and a third lead. This device is associated with even more quality of life, and that is consistent with large clinical trials. But the take-home message here is that the defibrillator does seem to provide people with some positive psychological experience, even though in many ways it's like a safety net. And that's encouraging in some ways. But the question is, how does it do that? I mean, is there really a way in which someone could get confident from the challenges that serious heart disease produces? One of the most imprinted ideas I have, if somebody were to say to me, what have you learned after all these years? And I could go on for weeks about the things I've learned from my patients who have been through cardiac arrest or ICDs, is I truly believe this, that when everything you love, everything that you care about, both yourself and others, and when your future, when it's all been risked, when it's all been flashed, you walk away with you walk away with a special knowledge that life is actually not so guaranteed. And that means then that we have to choose some things. We have to make some decisions and live in certain ways that reflect that reality. I think that's special knowledge. I think it's special knowledge when you can transcend the day-to-day doldrums, the day-to-day things that people get down about or get frustrated by and say, yeah, it's annoying, but I'm still happy to be here in a way. And I don't think that's Pollyannish. I think that is wisdom created from threat. So sometimes psychological growth comes from being kicked, being harmed, being threatened. And I think that's special knowledge. I think in the midst of all this, we can actually grow. And I think that's the building block. I think that's when you get a shirt like this and you say, nice try hard, I'm still here. You start getting a little swagger. You start saying, what you got? You got anything worse? Because I've been through this. And you start getting a little bit of a little bit of swagger about, I'm going to do this. I'm going to move on. I'm going to pick my priorities. I'm going to go live in ways that does and actually produce confidence. But it is not an challenges are real. If you look at the data around ICD patients, the data suggests that 1 in 5, 22%, experience anxiety. This is not that easy. That's about 2x what we'd expect from a non-cardiac sample. Depression's just a touch higher than we expect in a normal sample of same age peers. But PTSD is quite a bit higher, right? So the rates of PTSD in the general population range 4 to 7%. And so you start seeing these numbers and start saying, okay, so the psychologic harm done from a cardiac event is more anxiety than depression and a touch more trauma than just anxiety. Now, if you listen to cardiologists all day, they'll say, "Oh, they all have PTSD." Well, that's not accurate. What they're often saying is that the experiences shook them up, but the diagnosis of PTSD is very formal. It has very specific criteria. I don't want to get into the nomenclature as much as I want to say, look, yeah, people get stirred up. So the probability of anxiety is reasonably high. And it turns out spouses face a similar threat or risk. If there's any spouses on the call today, the rate, look at this, 20, what was it? 22% anxiety in ICD patients? Oh, and 22% for ICD spouses, suggesting that this is not just a singular experience, it's a team experience, it's a family experience. And spouses, as you know, will come along on clinic visits, but they're not the one gets to talk. They're not the one the care is provided to. So, in fact, spouses often have an unspoken anxiety And these are from large studies. I mean, this is from 109 studies with 39,000 ICD patients. These are not, I mean, we're not unsure about this data. These are big, multiple studies. 39,000 ICD patients. I mean, guys, that's a bunch of people. And so this is an impressive study. Some of our studies are mixed into this, but this group of researchers in Europe put it all together. And I don't know if there's many parents on the line today, but parents are particularly sensitized to the things they see. And we all know this, if you're in charge of another living organism, uh, whether that be a child, a dog, or anything else, you know how helpless it feels to see who you love in trouble. So not surprisingly that um, parents show particularly strain. And this was a study we did together with Stanford, looking at all of the families that came through the Stanford clinics in a given year. And you see the rates of PTSD much higher for parents. So we also know that about when you get more specific and you say, well, before we were just talking about general anxiety, now we're talking about specifically how many of people are afraid of being shocked with a defibrillator. Now you start to move toward a more precise question. One of my students asked me a question today, and I said, look, here's the deal. Being afraid of shock and asking somebody, are you afraid of shock, is completely different. And most people go around and say, well, I'm afraid of snakes. And then somebody comes up to you and goes, hey, are you afraid of wildlife? Well, I mean, I don't know, maybe. But the same thing's true. Like, are you anxious? Well, maybe, but I'm mostly anxious about a specific thing. And so this general versus specific anxiety question turns out to be pretty important. And so I think that should be reassuring a little bit from the standpoint of, many people with ICDs, they're doing fine, but they are worried about a very specific thing. Just like you can go out, most people who have snake phobia can go and walk in their yard. I mean, they may not go out in the woods and, look for rattlers. But on the other hand, they can go out in their yard. And I think this is the difference. You have to be very specific when you talk about anxiety. So, shock anxiety and specific fears that go with that are things like not understanding how you say ICD works, being avoidant of activity or emotions, things like being afraid of triggering a shock or recurring a problem, things like, oh, I can't exercise. These are the ways, symptom prediction. Oh, if I do that, bad things are going to happen to me. And I say it that way because it's not just, I hope I don't get shocked. The results of hoping you don't get shocked can be broad and diverse and what I call concentric. So it starts with a very specific fear, but it becomes very generalized, like a pebble in a pond, where the specific anxiety starts it, but then you have this generating or this concentric circling of anxiety that goes out from that. To me, these are the sort of waves outside of fears of shock. Now, the best way we think about this, if you were to come see me in clinic and you say, well, I want to see Dr. Sears for whatever reason, you would come and we would focus on these three elements, the reds and greens here. Cardiac events, trigger, thoughts about, oh my gosh, I'm in big trouble. This is a very dangerous condition, part of which is true, but part of which means that some people say, well, if I get shocked, it'll be the worst thing that ever happened to me. And that's catastrophic thinking. So you spend all day worrying about the worst case scenario. Avoidance behavior, which is, oh, I'll just, you know what, I'm scared. So what I'm going to do is stay home and watch Netflix. I'm going to be the most Netflix watched person that's ever walked. And so I'm going to be Mr. and Miss Netflix, and you're never going to see me. I won't see the light of day again. I'll just stay inside because that way I'll protect my heart, which won't work. And then hypervigilance, which means, well, I know what I'm going to do. I'm going to have the perfect records. I'm going to monitor my blood pressure. I'm going to monitor my heart rate 50 times a day. I'm going to have the most information ever gotten about my blood pressure and heart rate. And that way I'll prevent shocks, none of which will work. But all three of these are completely normal, completely understandable. There's nothing crazy about them, except they won't work. And they'll drive you nuts trying to do them. And so we focus on these three elements as a way to try to penetrate and not just simply say, are you scared? Well, anybody can ask that. The question is, what is contributing to the anxiety? What's contributing to the fear? And so this idea of moving us back toward thinking about, well, we want a safety net. We want to know what it is we've got, that medications and devices provide us with a safety net. And that coping really is a thumbprint. Each of us cope in our own unique ways, but coping generally falls into one of two camps in general, according to research, which is this very idea about the serenity prayer, where God grant me the serenity to accept the things I can't change. So tactics in which we cope with our feelings or our responses to something because we can't change what happened versus things we can do to change what's happening to actually directly affect the outcome. But importantly, the wisdom to know the difference. You know, the person that says, I'm firing my cardiologist. I'm so mad I had a heart attack. I'm firing them. And you go, you know that cardiologists don't cause heart attack. Yeah, but I'm firing them anyway because then I'll feel better. And you go, but that's a mismatch. Or the person who is smoking and not taking care of themselves says, well, you know what? Let's talk about emotions all day instead of, hey, how about we quit smoking too? And so it's not one or the other, it's all, right? It's a little bit of everything. That makes us the best. Now, what I got planned for us the rest of the afternoon is talk about five things that I think cardiologists would tell us if we could get them to tell us some things. If you had a longer clinic visit, you weren't just feeling like you're going in through a car wash and coming out the other end, you know, what would they tell us? What are the secrets that they don't have time to tell us? Let's look at five of these today. I could do this for all day. You know, nobody wants to hear me talk that long. But if I had all day, we would do five more. But let's talk about five. We'll talk about know and trust your ICD. We talk about you don't cause shocks. We talk about anxiety, about overestimating bad things. Then we talk about engagement or avoiding avoidance. And then we'll talk about the ICDs in planning and family. We'll finish and we'll talk and do some questions. So the first idea that I want to share with you is know and trust your ICD. When people have had bad things happen to them, and I get most of the bad things that happen to people on the Eastern Seaboard that have a defibrillator come to my clinic. So I see the 1 in a million thing that happened to somebody with a defibrillator. You know, a person that fell out of an airplane with no parachute, but got one on the way down and landed sideways and then fell in a tree and grabbed a bird and then an eagle took them off and then they landed. You know, that's the one I get to see. Now, know and trust your ICD means that, you know, this technology truly is amazing. And the more you learn about it, the more confident you will be. Now, a lot of people go, I just can't deal with it. I just can't talk about it. I just do what you have to do. I don't want to look like it's some sort of shot. But the difference is it's a little bit like someone handing you a rock and saying, here's a rock. And you go, I don't like rocks. Why did you give me a rock? I hate rocks.
Hmm.
The rock is a diamond. But you don't know what a diamond is. You've never seen a diamond before. How would you know if there was any value to it? This looks like a rock to me. Frankly, it does look like a rock to me, still does. But my wife says they're cool. So, understanding a defibrillator is actually a value that you don't necessarily know. This silly thing here by box of tricks under the skin. You know, I'm looking for a little bit more knowledge about your ICD than that. But the most important thing about your knowing your ICD is that it can keep you safe. That is the gold standard of knowing what you have with a defibrillator. And the data says that actually people kind of get it. Here's that same 1,800 person sample of Europeans, and they're running around Europe, you know, having, I don't know, French bread and, I don't know, Danishes or something. And they have this idea that their number one benefit of having a defibrillator, the number one benefit, feeling safer with my ICD. 80% said they felt safer.
No.
But but the tricky trick is that the number one concern is shock, and the numbers are close. Now that's confusing, right? If I told you that my favorite pet was my pet lion, but I'm also afraid he might eat me one night, it's hard to actually feel good about my pet lion. Let's call him Leo. So Leo, you know, how do I do with Leo? Do I pet Leo or do I run from Leo? Since both are probably true. So it's confusing. And we already talked about this with this idea of PTSD and the challenges and all that. But fundamentally, it's like, well, should I scream or should I feel safe? And this is why you guys probably had me on today. It's like I don't think you wanted to see my hairdo. So here I am, you know, talking about this stuff. Uh it does look good though, doesn't it? I mean, I styled it. But conceptually, you know, all you have here is this idea of should I feel safe? Should I focus on the fact that I have a pet lion? Or should I focus on the fact I have a pet lion? Or should I focus on the fact that I have a defibrillator that protects me? Or should I focus on the fact that I need protection? Like, that's a pretty confusing message, but I think it's really an important idea that feeling safe is a work in progress. Somebody
Hmm.
made this slide somewhere on the internet and I picked it up. about things that I said one day when I was on a rant, which I'm on now, so you can see. But, this rant of how do I help people feel safe? Start small. What are some ways in which you can take steps toward being confident? Get help from loved ones. Hey, I want to go to the mall. I want to I want to go on a bike ride. I want to go on a walk. I want to do whatever and focus on how do we make some changes. Expect to be a little bit anxious. That anxiety will occur. And remember that as we get every little step counts.
Mm.
Strategic test the limits is my concept. And so knowing and trusting your ICD is just a building block for these other things. But we can't avoid the second one, which is you don't cause shocks. Everybody wants to know, I don't want any shocks. I don't want any shocks. Don't cause shocks. Well, what do we know about that? What do we know about ICD shocks? How do we prevent ICD shocks? First and
How
foremost,
deeply?
prevent ICD shocks by medications so that we control heart rate and rhythm using our medications. We can use ablation and other kinds of techniques using catheters to reduce the circuits that can occur. So knowing about and using optimal programming, we make the device as smart as possible to fit your heart, the things your heart does. So, the reason that we want to control shock is not just shock. Yeah, shock is shock, but the thing is, it's less than 1 second. So we're worried about something that occurs so fast that we actually have to perceive it after it's over. That's kind of weird. So we're perceiving something when it's over and then concluding what it felt like. But that's the problem with shock, is that shock is known to be an uncomfortable stimulus. Everybody knows that. Every vertebrate, any animal that has a spinal cord doesn't like that because electricity causes both contraction and lengthening at the same time. That's why you're kind of stuck, right, when you hit like an electric fence. So one of the things we talk about is knowing exactly how to respond to a shock, that to use shock as a standard operating procedure situation. So for example, everybody should know exactly what you should do when shocked. This is the standard action plan that we wrote about almost 25 years ago, in which you receive a shock, feel fine, let your clinic know. Receive a shock and have any symptoms, get seen. And anytime you get two or more shocks, doesn't matter how you feel, get seen. So really, this idea is pretty simple about what to do. Like there is no run around and worry that you got shocked. There is a take inventory and make a plan. And then responding to shock after the shock's been adjudicated, examined by your medical team. Okay, so then what do we need to do? We got to come back and teach ourselves, okay, we're over aroused. Let's focus on, we made changes to the device to keep you safe. We talked about why you got shocked. The device read this, it thought that, it took that action. But ultimately, confidence is won by returning to that activity. The vast, 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 vast majority of activities are returnable to. And that is how we overcome fears. So what else do we know? This is a really, really important study. This was a meta-analysis in General Hospital Psychiatry that came out about 18 months ago. And in this study, they took all of the studies we've ever written and all of the studies this group's ever written, which is most of them. And there were 37 studies with 35,000 ICD patients in the study. Again, we're not unsure here. And they wanted to ask the question, does anxiety or depression cause the defibrillator to go off? And the answer is no, it does not. And there are many reasons. I can do this all day, but there are many reasons why that's not true. But what they also showed was that anxiety and depression can be linked to bad outcomes if it's not managed, if it's not dealt with, meaning that anxious and depressed people can give up. They can stop taking their medicines. They can stop engaging in their care. They can do things that will wind up being associated with bad things. But this data tells us very clearly this is not some sort of I made myself get shocked. Could you imagine if anxiety and depression caused ventricular arrhythmias? Everybody who ever gave a speech, down on the ground. Every teenager that ever went on a date, down on the ground. Everybody who's ever done anything that scared them would be on the ground. Thank God our bodies are strong. Our hearts are strong. Our ability to encounter the stresses and losses and grief and grind that life gives us is still in place, even if you have a defibrillator. So no one trusts your ICD. You don't cause shocks. What else? You probably overestimate your chances of getting shocked. You know, these days we don't shock people like we used to. When I first started, we shocked 40% of patients in the first year of having a defibrillator. 40%. It's like, get ready, buddy. We put this in. Here comes the shock. But not today. Guideline-directed medical therapy has greatly reduced how much shocks we use. Medicines reduce shocks. Secondly, we're smarter about how we program devices. We had reduced shocks tremendously. Remote monitoring also reduces shocks. Having that bedside monitor, sending data, we can get ahead of problems before they ever occur, and annual shock rates have declined. So much so that in this study, for example, a study that used our measure of shock anxiety, this time we have 1,200 ICD patients. And in this study, they showed that the overall shock rate was 2.6% appropriate and 2.6% inappropriate, resulting in what I always say is a 4 to 6% chance of shock in a given year. So 94 to 96% of ICD patients will live an entire year and nothing will happen. That device will be silent. And year over year over year over year, you see a low chance of being shocked. Now, it's not zero. I get that. We'll get to zero someday. We are going to get to zero. We're going to get to where we can prevent these. But the very idea here is that
Hello.
the very
Well,
idea is that we can get there. That this is a low shock rate. And actually the two most common fears were exercise and simply the heart beating faster. So this study continues to teach us about, yeah, shock and shock anxiety remain important, but we probably don't have a high chance of shock. You're much more likely not to get shocked in a given year than to be shocked. Wait, it's not even close. And I already talked a little bit about this idea of shock anxiety turns out to be the most common kind of problem. These are the traditional mental health disorders, but shock anxiety is by far the most common concern. So that's why we have a meeting like today to talk about shock anxiety, because I'm not afraid to talk about it. You know, some of your team won't be very comfortable talking about this because they don't know, but this is absolutely okay to talk about. Avoidance activity is a high rate. People will avoid things. And finally, lots of people don't understand what we have here with a defibrillator. So this is just part of this process of trying to reduce some of your anxiety via knowledge. The chances of shock are low, and more importantly is our response to the threat of shock. And we know different kinds of people who are more likely to report that. People less than 50 years of age are consistently more likely to have anxiety with a cardiac condition, and it goes to show there. Women across the lifespan are much more likely to report depression or anxiety than men. Multiple shocks, previous psychologic problems, people who feel isolated or alone, poor understanding of your condition, and more severe medical conditions where you have lots of other things going wrong, this is more likely to produce distress. Over on the resilience side, things like optimism and faith in ICD and doctor are the two that I would highlight as being helpful to resist. When you ask patients, well, what do you need to get better? These qualitative, this time we have 24 papers that were reviewed, and this time fear and insecurity still number one, but need for information two, impacts on life, living with shocks, gender differences, role of family. So, these are important conversations we're having here on this call and always, learning about all of these things is important. I make a lot of videos trying to help people deal with these. There's things on Reddit, there are things on across the internet, some of which are good, some of which are bad, but certainly, there's lots of ways to keep learning. And I think reaching out and learning is part of overcoming anxiety. So what about engage? We've talked about all three of these now. What about avoid avoidance? What does that even mean? How do you avoid avoidance? Well, it means that movement's medicine. That is, heart patients of all sorts need to move. There are only a couple of conditions in which we say, okay, let's not become marathon runners. The vast majority of conditions can actually move a good deal. Movement's great. Movement makes you mentally healthy and physically healthy. Movement's great. Yeah, actually talk to your doctor. But of course, movement is good for all of us. We are built of muscles and bones. You have to move them. So does that even really work? The data suggests that it does work in now multiple randomized controlled trials using psychotherapy, helping people get back into activity, reduced anxiety. In exercise programs for ICD patients, again, 6 randomized controlled trials, conclusion, less ICD shocks if you exercise, less ICD shocks if you exercise. Going and doing is good for your mind and your heart and your body. What do you love to do? I mean, you got to know what you love to do. I don't know what you want to do. You got to figure out what you love to do. What are some activities that are fun for you? Like I love to drink coffee. Got one right here. It's 4:30 in the afternoon. I better be careful. But I love coffee. I think it's fun. It's as close to a smoke break as I think any of us should get, right? We all take a break. We're gonna get some coffee. All right, cool. It's a pretty good spot here, right? Looking at the Harbor Bridge, you got the Sydney, Australia, right there. It's not a bad shot right there. It's a special spot right there. But doing things means that you have to encounter anxiety. I want to do this, do it. But I'm scared. Do it scared. That part of the recovery is doing some things scared. I'm not suggesting being reckless. I'm saying, hey, things that be comfortable with some discomfort. Because this is the avoidance characteristic, right? I talked about this model earlier. If we don't do stuff, if I just sit here and cheerlead, that's only going to address this. You still have these other mechanisms in which the event can cause fear. Avoidance, checking out, disengaging will only continue anxiety. It's like the fuel that anxiety runs on. I run on coffee. Now, but specifically, so how do we do this, right? We do this by talking about deliberate reassurance, reminding ourselves that, yes, I'm safe and I'm strong. I know this is hard, but I can do it. I can focus on the survivorship, not the victimhood. Victimhood only leads you to lose. Survivors try to keep gaining and get back into the swing of things, right? Get approval, get what you need to get confidence back from your medical team and go. Celebrate the small victories, recognize every little baby step. This silly movie was funny because it talked about small baby steps, small ways in which you can make progress. Because the only thing that can create positive actions is doing stuff. I'm sorry, positive feelings is created by positive actions. So we're rocking and rolling here, right? We talked about one of the building blocks of psychological health is trusting your ICD because that's the safety net. Secondly, you can't cause shocks. The only thing that causes shocks is you not following the medicine that you need. But otherwise, the device is there as a safety net. I don't want to bubble wrap you. Anxiety. We overestimate our chances of shock. Shock's a less event than it's ever been in the history of our care with this device and with patients like you. Avoid avoidance. Re-engaging is what will create confidence. And finally, now the ICD is implanted in a family. So why do we know that? Like, what is that about? That sounds like some sort of pop psychology. But the problem is really not. I mean, our loved ones are on a amusement ride of life together. I took this picture of these ladies because I thought it was just kind of interesting, right? I think they were sisters. Heart failure survivor, heart failure coach. Or this lady, I've been shocked back to life 6 times by a defibrillator in my damaged heart, and here she is with her, uh, her, uh, her. I'm sorry, he's the patient, and she's the. I'd see she got Taylor Swift on there, but in particular, uh, this is his spouse saying she's in it with him, and the same thing's true. We see this idea about two people who experience a heart problem. And the data actually supports this. In a large clinical trial done at the University of Washington by Cindy Doherty, she studied 301 patients and partners. And what she did was she randomized a patient into what I'll call an ICD school, teaching them about the defibrillator. And the patient had to go by themselves versus the patient going with their partner. So they were a team in one or an individual in the other. And the data suggested that when the patient and partner went together, there was more benefit. Partners and patients, the patient said, well, I have less symptoms, I feel less depressed, more confident, and have better expectations about the future as me and my partner went together and got empowered. Partners reported that they felt better about taking care of their family member and that they learned more about the defibrillator as well. But I want to give you one caution. Partner anxiety and depression were stable. That addressing specifically partners and spouses' anxiety was not, it wasn't effective in this case. Partners felt better, but not so much about their own anxiety and depression. They felt better about the partner. So this means that this relationship between who's in it with you really does matter, and that we're not in this thing by ourselves. So when you think about these five things, I think these are five things that your cardiologist would try to tell you if they could. The cardiologist would say, you got to trust this ICD. That's your safety net. You got to trigger in a shock. You ain't going to. Let's think about anxiety and shock and say, wait a second, I've done everything possible. Everybody in this team has done everything possible so that you will never get shocked. But you will get shocked if you need a shock. And that's the only time we want you shocked. And we want you shocked one time and out and safe. And further, the purpose of this thing, the inventors of the ICD, one of which I had the great honor of meeting, that Morty Maurer and was one of the inventors. Morty Maurer would say, "Man, I just want to put people back into their life. The purpose of this thing was to protect them so they just go back and be in who they were before. And avoiding avoidance means getting back into life. And then finally, you got to get help. You can't do it all by yourself. There's not very many Lone Rangers in the world. I mean, their show got canceled. It wasn't even good enough for a long run. I mean, Lone Rangers, who wants to see that, right? I mean, we like teams. Yeah. There's some great athletes out there, but they usually have teams. And so, I think you still got it. I don't think defibrillators takes it away from you. I think you still got it. If you were a jerk before, you're probably still a jerk. If you were great before, you're probably still great. You still got it. You're still here. And I think bringing that out and making sure that you recognize, hey, this goes beyond simply the idea that you have a defibrillator. This is still back to pulling the special knowledge, pulling the special wisdom and priorities that come with this. That if we can do that, when you can make sense of this by saying, okay, I didn't want this, I didn't love this, but I'm going to restore my life and take these wisdoms and take these experiences and restore confidence via the kinds of things we talked about. That's what restoring confidence is about, is getting back into living and being the person that you were before. Thanks very much. Nothing like a quiet applause.
Thank
Happy
you.
to take some
Thank you
questions.
so much, Sam. I should say Dr. Sears. That was great. Francesco has a question.
Great.
Thanks a lot, Samuel. Yeah,
Hey,
if
dude.
if if this video was available, I'd put it on the British Art Foundation website here where I am in the UK. Now, what Cardiomyopathy UK and some of our organisations are doing in the UK is looking at a 6-week online course for the very types of patients that you're talking about, which you'll be familiar with, which is the acceptance and commitment
Yes.
therapy.
Yeah, it's
Yeah.
fantastic.
So it's to be honest, we're looking at sort of like what you mentioned about, well, physical activity, exercise, along with psychological well-being, and then of course you've got dietary and nutrition. But unfortunately, when I had my cardiac arrest, I just got, put my had my ICD and offered nothing because they didn't have that system in place. Whereas now, is starting to follow the cardiac multimodal components of support, which has been mentioned. So it's absolutely fantastic. But a lot of patients they brick it big time. They talk about, the anxiety, the depression, talking therapies that they can't access. So I think if they were to be reassured by seeing your video, it would save them maybe developing abdominal aortic aneurysm, or sort of like worrying about hypertension or barrio bradycardia or whatever, because all this made sense because I've not heard it in this way. So many thanks. Thank you.
Well, what a kind comment, and thank you for those words. I do think this is why I do these, and this, I've been doing this a long time, and I think so. I like to start some of my talks to cardiologists with kind of an intellectual punch, and I say, "Hello, cardiologist. Hi, I'm here. There's no such thing as cardiology without psychology, so stop practicing without it." Meaning that
Yeah.
as long as you're providing care to someone's heart, then you are affecting their mind. And cardiology has to progress. I mean, cardiology at times was led by tremendously courageous medical cowboys. And later we got some cowgirls, but it was made by people who had ridiculous levels of courage, but not a lot of psychologic sensibilities because that wouldn't have helped them, frankly. I mean, nobody wants the depressed and anxious cardiac surgeon. Well, I don't know, you know, it sort of draws on people who are like, let's go. And that's great. But just like all of us, we want to build teams that can address the whole person. And so to me, I'm glad to hear that Great Britain is doing some of that work now. A little anecdote. I would say probably 25 years ago, I provided documents to NICE, which is the National Institute of Clinical Excellence, which is kind of like a regulatory body in the UK. I actually provided testimony that I thought all ICD patients in Great Britain should receive psychologic care at least on one session. Uh, it was written in the document. I don't know. I've never looked again, but it was written in the document, but it was unexecutable because there was no one who could do it. So I basically said, everybody needs to go to Mars. Okay, great, thanks. It was what do they? No one could do it because I was saying that they needed psychological care, but there's not enough human beings to provide the care, and there was no expertise. So I might as well have told him to do something silly. Um, so I'm glad to hear that. And acceptance commitment therapy you mentioned is also interesting, right? This is a therapy that basically involves learning to cope with our responses and recognizing we don't control everything and that we can tolerate emotions, that negative emotions are not dangerous, they're not deadly, they won't hurt us. Anxiety makes it feel like you might die, but you're not going to. And I think that's the hardest part about anxiety, particularly with our young people, our adolescents. They experience anxiety for the first time and they think, oh my God, I'm going to die from this. And it's like, it does feel like that, but you won't.
Thank
But
you.
thanks for your comments. I went on too long, but you excited me.
There was a comment from Tracy. I don't know if
Yep.
she's still on the call.
She made
Um,
a comment and ran.
but she just said she's not on medication, but she's still in heart failure. I don't
Okay.
know if you want to comment on that.
Yeah, I think the key is just that with all of these medicines now and these conditions, it's no longer one disease, one medicine. That's not how this works. These aren't infectious diseases where you have a specific bacteria and a specific antibiotic. These are multifaceted, multi-system disorders where we're trying to control blood pressure, heart rate, lipids, cardiac contractility. We have a complicated approach to protect people now. The goal of all of that nonsense, all of that ridiculous level of medical technology is for you to feel safe again. We've got to get you to safe. Once you get to safe and you say, okay, I'm not in active danger, now we can turn the corner and start to talk about, okay, so let's talk about now going and getting some good stuff,
Mhm.
right? Going and getting good stuff means going planning to go have a trip that where you have a sense of awe. Plan a trip in which you have a sense of peace. Have a trip where you plan to be closer to the people that you love. Have a trip where you plan to be excited and see something and be a part of something that's a group. Around here, protest something. Why not? You know, there's a few things going on I want to protest right now. So, there are things that we can protest. There are things that we can care about. We can volunteer to give our heart, to actually put more out there than we take in. And honestly, then we're actually alive. We're actually alive when you give more than you took. that's to me the thing, and that the data. That's not just Pollyannish poems, or I'm not a philosophy professor. That data says when we do something for somebody else, we get a more of a mood lift than any other single behavior.
Patrick, did you have a question?
I do. First, I have a comment. Thank you so much.
My
My
pleasure.
next thing is, so I've had my ICD 3 years. I've been shocked 3 times. The first time I had no symptoms. The second time I had a symptom for seconds, and then I got
Yeah.
shocked. And my third one, I kind of knew I wasn't feeling good for a while before I got shocked. So three different, things. I exercise every single day.
Good.
And every single time I got shocked, I was exercising.
Okay.
And I'm on all these, like, what do they call them, the 4 pillars of heart health, right?
Quad therapy. Yeah.
Right.
Quad therapy.
So yeah, so I take all that stuff.
Yeah.
So and I really don't have any anxiety.
Good.
I go to Mount Sinai in Manhattan, which is a very good heart.
Yeah. It turns out they're okay up there at
Yeah,
Mount.
they're okay.
One of the best places in the
But
world. But yeah,
you know,
sure. They'll
yeah,
get by with you.
but they tell me I need to do a better job monitoring. So I'm kind of the opposite of what you're implying, right? Is like, don't be so hung up with, getting shocked and whatever, right? And I'm really the other way. I'm kind of like, I pay no attention to it. But
Okay.
then I get shocked. But then the doctors say, you need to spend more time paying attention to your body, as part of whatever living.
Mhm.
Yeah. So okay. So here's how I would handle your situation. So you're a little bit tougher case than most. So most people will come to me and say, I've been shocked twice. One time I was sleeping and one time I was exercising. And I say, so there you go. What you're doing doesn't matter.
Mhm.
Because how could the both can't be true? You can't say, well, exercise causes shock, sleep causes shock.
Right.
Okay. So since you've had all exercise, the next thing I would say, were those all appropriate shocks and necessary? Were you in
Oh
V?
yeah, I was in VFib. They established I was in VFib for every
Uh-huh.
one of those times happened. So
Okay.
I needed it, which thank God.
Right.
But
So the next thing they're going to do, though, is either put you on more beta blocker and block your rate down, right?
yeah.
So that you won't be able to get up high from exercise.
Mhm.
The when they're telling you to monitor, I think what they're trying to say is don't be reckless. They didn't tell you
Yes,
to
yeah,
do any
that's right.
exercise.
No, you're right. It is kind
Right?
of like
So
stuff. And I am a little stupid, as far as I do what I want. I was cutting trees before this call, like I do stuff because
yeah,
I just
yeah,
kind of, that's just who I am. I'm ADHD as well.
yeah.
So I
So
move.
yeah. So cutting trees is a separate thing, right? I mean,
Right,
I worry about me cutting trees. I just don't think I should do that anymore. I'm getting
right,
older. Cutting trees just a generic problem since turns out this looks like a tree limb sometimes. You know,
correct.
so you got to be pretty careful, period. Some of this is just selecting behaviors. Uh, the one I always have, my patients are always trying to get on the roof to blow the leaves off.
I
You
do
know,
that. I just did that
check.
over the weekend.
That's like a marriage check. If you
Right,
do that and you have an ICD, the question is, do you want to stay married? That's really the question. If you want
right,
to not stay married, go ahead and do it.
right,
It has nothing to do with your cardiac condition. It has everything to
right,
do with your relationship.
right. So, but my kind of question was, is there a point that you think to yourself that, what, exercise is great and not paying attention and not being anxious with your ICD, totally the plan, but there is a plan too of awareness that, hey, I've got this because my heart isn't functioning properly. I'm in congestive heart failure, or I've got, some issues going on. So I still need to acknowledge that risk, and I need to also then behave in a way that acknowledges it but doesn't keep me from, living a life.
Yeah, and I think you're hitting the right point. That's clearly the point.
Mhm.
My comments are more for the disengaged person
Mhm.
about who's basically, I can't engage because I'm monitoring.
Mhm.
You're engaged. Now you just need to monitor a little bit. I mean, just be smart about it because that's what I think all they're saying is don't be reckless. They didn't tell you not to do stuff. They told you to do stuff with some
Right.
awareness. So I think
Yeah, be more aware. Right.
yeah, that's a reasonable comment. I might challenge them a little bit just from the standpoint of, okay, yeah, we're going to be aware, but what do you want me to do if I become aware? Stop? Okay,
I
well,
agree.
okay, I will
Yeah,
do
and
that.
it's the other way
Stop.
too, right? If I'm overly anxious, I can't do anything about that either, right? I'm getting
Right.
shocked or not get shot, right?
Yeah, so when I talk about that, it's like, okay, so you want to, and I said this to a cardiologist just this week. I said, look, your job's protection, and it's the number one job, protect our patients. My job is restoration, and I
Right,
want to challenge your protection. And so
right,
there's a tension between
hmm
restoration and protection, right?
right,
And
hmm
it should be tight. I want it to be tight. I want us to have these conversations because then we're getting the most out of both of us. But protection always wins, always.
hmm Thank
Always,
you.
because we can't play this game. Protection wins every time, but I want to
hmm
keep pulling you toward restoration.
hmm Thank you very much.
Sure.
Um, Sherry Olson, you have a question?
Hi, Sherry.
Hi, can you hear me?
Yeah,
Mhm.
loud and
Oh, well,
clear.
my question was just, I think it's really interesting that you showed a written action plan, and I'm just wondering if there's research studies on how many patients actually receive written action plans after their ICDs are placed.
Yeah, there's no data on that. So that
Wouldn't that
paper,
be a good study for you to do? Because I think it's very helpful and I hear people asking about it all the time. But I don't think that most institutions that take care of people provide that kind of a benefit for their ICD patients.
well, I love your comment, and you're exactly right that that needs to happen. You'd be surprised. I mean, people really There's not, I'll put it this way. I said there's no cardiology without psychology, but there's a lot of cardiology without psychology, it turns out. But it would be better if it had some psychology, which is a reasonable thing to do. If you put human beings in a situation where they're frightened, is to give them a standard operating procedure. The reason that
Totally.
standard operating procedure exists is because when we have high levels of distress, it's hard to think.
Mhm.
Standard operating procedures in our military create the opportunity in which, if you're highly aroused, do what we've trained you to do. Don't think. Do what we train you to do. Don't, this is not a time to go rogue. You're not Tom Cruise. You ain't Top Gun. Do what we train you to do. And what we train our patients to do is if you get shocked, I need you to first take inventory. Are you okay? Is anything hurt? Are you hurting anywhere? If you're hurting anywhere or you don't feel clear, go to the ER. If you get shocked and you feel fine, most clinics, not all, most clinics will say, just let us know. Send your rhythms via the remote monitoring. We're getting them anyway. If the device is set up in a certain way, we get them anyway. We get a red alert. That doesn't mean we'll see it right away, but we get the device communicates. But the thing is because when we get distressed, it's hard to think. I mean, that's okay. We're just humans. So that's why I think you're reacting that way, because a standard operating procedure or a plan, a shock plan, really helps. That paper's out there. You can download it. It's from Circulation in 2004. And I would bring it to your doctor and say, hey, is this what you want me to do? Because it used to be one of the most downloaded papers in all of Circulation's history. I don't know if it is anymore, but it's sort of
I just
silly.
think it's a really interesting point that it's been around for 20 years, and it would be really interesting to see how many um, ICD, how many EP doctors or patients who've had ICDs placed actually have that. So
Yeah,
maybe that's future
yeah,
research.
I'd say none. Basically, not very many. Just
Right.
kidding. Not many. Um,
But it would be hugely helpful.
yeah, if you ever could ask them and say, "What would you like for me to do if I got shocked?" Which is kind of a good question. They might spit that out per se,
Right.
which I'd be proud of that they would say that, but they probably wouldn't. They would react with that. They probably wouldn't proact with that.
Right.
Yeah.
Mhm.
Thank you.
Yeah, thank you.
And Sherry, you're a doctor, right? So you
Well,
probably
I am,
you're
but I've never seen a patient or heard of a patient who has received one of those. So
Mhm.
written.
Yeah,
So
I'd love for you to you grab the paper. It's out there. You can Google it. It's called How to Respond to an ICD Shock.
No.
I mean, it's pretty straightforward. Like, okay, how should I respond? It's written for patients and it was published in the journal Circulation, which is a important
Right.
cardiology journal.
Okay.
Uh,
Thank you.
yeah, thank you. What a good question. And I wish I could do that study to tell you the truth. I don't, but I don't think we'd find very many. We are actually, so one thing we're doing right now, we're planning a study to contact the top 50 heart centers in the United States, according to the U.S. News World Report, and find out how many have a psychiatrist, psychologist, or social worker that is readily available to manage heart patient concerns. And I'm expecting it to be like here at East Carolina and not many others. So now we have data on cancer clinics. So we know that 84% of cancer clinics in the United States have a psychologist, psychiatrist, social worker on staff ready to deal with cancer.
Hmm.
But we expect it to be in the single digits in terms of heart centers. So we're going to do
So
something about that.
one of my biases is as a primary care physician, and I'm retired now, is that when I had a patients with oncology, I would get something called a survivorship plan that
Mhm.
would get sent to me and to the patient so that they knew when they were done with their diagnosis, what meds they were on, what treatments they'd had, what to do if they had a shock, all that kind of stuff. And I've seen that in the cardiology world, but I don't think it's very universally done either. And that would be so helpful for everyone in dealing with their ICDs, I think, if that existed.
I have to admit, I have a sense of frustration about the question because I've been at this 30 years, man. My axe has been on this tree for 30 years and we still haven't cut it down very far. Um, and it's frustrating. So I mirror your frustration, but I'm also frustrated that we haven't been able to crack this very well, even though, I've given more lectures than some politician these days. But
Well,
this is
the Sudden Cardiac Arrest Foundation, we're working on discharge planning for
good.
survivors.
That's right. Yep.
And we're developing a document that will help hospitals to understand what they need to share with survivors before they leave the hospital and then after. So that's
Great.
yeah.
So that would get at the people that had a cardiac arrest, and we've got a lot of different kinds of patients out there, but this would be a great effort, right? And I know that's one of the things that CASA's been working on, and it will just be a big help. Every little bit helps.
Mm.
The Hypertrophic Cardiomyopathy Association's working on something, and just getting let's just chip away at this a little bit, and then we'll see where we get. Um, but this isn't that deep, guys. I mean, this is just comprehensive care. It's just being sensitive to, hey, you're a reasonable person that's dealt with an unreasonable event. That I don't think it's that. Show me the neuroticism. Show me the crazy. It ain't here. It's just normal people going, hey, man, this thing hit me sideways. And I just need to make sure that I'm all put together again and that I can step forward in the future.
Great. Well, I guess we're a little over the hour here. So thank you all for joining us. Thank you, Dr. Sears, for your
Thanks.
wisdom. Really,
Rants.
really, really
Thanks for my
helpful.
rants. I
And
love being here. Thank you.
yeah, we're going to share this online, this video, so people who weren't able to be here will be able to see it later. So anyway, thank you all so much.
Thanks, everybody.
Take care. Bye-bye.
Thank you. Thank you.
Oops.